Okay, so MCCQE1 Objective 1, it's abdominal distension. In other words, the MCC wants you to know how to deal with cases of abdominal distension in your exam preparation. So we're going to dive into abdominal distension cases right away. Now, as we know, we have to use the objectives to study. So if you have a patient with abdominal distension, the MCC wants the candidate to list and interpret critical clinical findings, including lists and interpret critical clinical findings, including perform an appropriate history and physical exam to differentiate ascites from the standard bowel. Okay, so please write it down. If I were you, if I'm studying this objective, I'm going to make sure that I know how to differentiate the difference between ascites and the standard bowel. Of course, ascites will have fluid thrill. The standard bowel will have percussion note, which is tympanitic, right? But that is not the focus of our studies today. Also, you have to be able to identify the underlying cause of ascites or bowel distension. Very critical. You must be able to tell what is the cause of, this ascites, or what is the cause of this bowel distension. Now, the enabling objective is that you have to list and interpret critical investigations. So I'll be giving you some questions on that as well, where you're going to deal with laboratory investigations and imaging. So you will see that some questions will be coming about lab investigations, imaging, liver enzymes, abdominal imaging, including 3 views of the abdomen, ultrasound, and paracentesis. So that means in your exam preparation as well, you must be able to know what you're going to even do with paracentesis fluid. So if you take fluid from the abdomen of a patient, you must know what exactly you're going to do with it. The MCC wants you to know. All right, please. So we continue in the class right now. And then you have to be able to construct an effective plan, including initiate specific therapy in the case of ascites. So dietary changes, therapeutic paracentesis, initiate specific therapy in case of mechanical or paralytic bowel obstruction, and determine if the patient requires specialized care. So as we do all the time, we are going to use question-based approach to study this. Of course, we cannot cover all the topics, but by the time we are done with this class, what I'm going to let you know is when it comes to this objective, based on the objectives, what are the high yield points you must know? What are the high yield points you must know? Okay, so let's dive right into the case. I will need volunteers as we do all the time. So who is going to be our first volunteer? Dr. Tasnim. Beautiful. Okay, so Dr. Tasnim, first question is going to be basically CDMs and some MCQs. There will be a lot of questions. So Dr. Tasnim, let's go.
Sure. You are practicing in your clinic today. A long time yours into the clinic with abdominal distension. List 5 causes of ascites.
Beautiful. This is your first question, Dr. Tasnim. What are 5 causes of ascites? Because you need to know. What are the causes of
most common liver cirrhosis.
Liver cirrhosis, okay.
Okay. Any malignancy, either pelvic malignancy, GI malignancy can also be a differential. But to be, I would say like a liver CHC. Should I say that exactly?
Yes, say it as you say it in the exam. Write it, say it as you say it in the exam.
Yes. Okay. Ovarian cancer.
Okay, let's go. Ovarian cancer. Let's go. What else?
Even liver cancer.
Liver cancer. Let's go.
Other causes of ascites.
Yes.
We have transudate and exudate, right?
Fine. So tell me, what are your causes?
Okay. So let's also do infectious disease too.
Like what?
I know even extrapulmonary tuberculosis can be a cause of effusions.
So you've said ovarian, hepatocellular, tuberculosis. Talk about some of the common ones as well. What are some common causes of ascites? Let's go.
Hepatitis, severe hepatitis.
Well, hepatitis itself will not cause it. It is the complication of hepatitis, right? Which will cause that. So, so I've seen some people writing congestive heart failure, chronic kidney disease, nephrotic syndrome, right ventricular failure, ovarian cancer, liver cirrhosis, congestive cardiac failure, right? But hey, the one who wrote right ventricular failure and congestive cardiac failure, if you write both, you're going to get just one, because right ventricular failure is part of congestive cardiac failure. Please, are you following me? So the one who wrote right ventricular failure and added congestive cardiac failure, I know maybe you've run out of options, but if you write both, you're going to get only one answer, right? Okay, so Dr. Tasman, yes, you gave me about 3 of them. That is awesome. So what are some of them? Cirrhosis, okay, alcoholic hepatitis. These answers are from up to date. Even acute liver failure can give you some form of ascites. Hepatic veno-occlusive disease, for example, Budd-Chiari syndrome, heart failure. All right. So please write these answers down. Write them down. You must know the causes of ascites. Constrictive pericarditis can also do that. Hemodialysis associated ascites like nephrogenic ascites. Okay. Nephrotic syndrome. Protein losing enteropathy. You know, if the patient is losing a lot of protein, that means oncotic pressure in the blood vessel has gone down, and there will be a lot of transudates. You know, so Dr. Tasman, as you said, there'll be a lot of transudates into the abdominal cavity, and that can lead to ascites, even severe malnutrition. Okay, so one thing I want you to do is that, especially if you're writing your answers, do your best to go across different organ systems, different conditions. So if you can get one infection, if you can get, you know, one chronic condition, if you can get one heart-related condition, but you can write all these and you'll be right. Please, are we okay? Are we all okay? Are we all right? Can we move on to the next question? Because you must know the causes of ascites. Let's go to the next question. Even more answers. So malignant ascites like ovarian cancer. So Dr. Tasnim, you were right. Mesothelioma, okay? Infectious peritonitis like tuberculosis. So you were right. Eosinophilic gastroenteritis. But what I want to say is that, look, get about 6 of them, and keep that in your mind, that this is what I'm going to stick with if I need to produce answers on causes of ascites. And what I need you to do is recite them, look in the mirror, recite them, okay? Starch granulomatous peritonitis, peritoneal dialysis, multicystic mesothelioma, chylous ascites, pancreatic ascites, myxedema, hemoperitoneum. So hemoperitoneum will be from like maybe a motor vehicle accident, right? Like trauma, okay? And even urologic injury. So if there's a tear in the ureter or something, the urine can seep into the abdomen. And this is all from Up to Date. And you know that Up to Date is the MCC's recommended book. Okay, who is going to be our next volunteer? Dr. Tasnin, you want to continue, or someone else wants to volunteer?
If there's no one, I can continue.
Sure, Dr. Tasnin, let's go. Let's go, yeah. That's good. Thank you for your courage. Let's go.
You are practicing in your clinic today. A long-time patient of yours comes to the clinic with abdominal distension. Patient inquires about the complication of portal hypertension. Okay.
Yeah. What are the complications of portal hypertension?
Esophageal varices.
Mm-hmm.
There will be also splenomegaly, hepatomegaly.
So it can cause splenohepatomegaly, right? Beautiful. Let's go on.
Another fourth, even like capitis mediosa, it's not a major complication, it's just other signs of it. Internal hemorrhoids with bleeding. Yeah.
Okay, so you're talking about some complications. So complications of portal hypertension. Know this. You need to know that it can lead to ascites itself. It can lead to hepatic encephalopathy. It can lead to variceal hemorrhage, as you said. It can lead to even spontaneous bacterial peritonitis. So the whole issue with spontaneous bacterial peritonitis is the portal hypertension will lead to ascites, and when the ascites gets infected, then that can lead to spontaneous bacterial peritonitis. It can lead to hepatorenal syndrome. That's what you were talking about. You even talked about hepatomegaly, you talked about splenomegaly. It can lead to portal hypertensive gastropathy. It can lead to hepatic hydrothorax. So some people develop, portal hypertension, and because of that, they also develop some fluid in their lungs. Okay? They develop some fluid in their lungs as well. So those are all complications. they can also have hepatopulmonary syndrome. So Dr. Tasnim and anyone listening, it can be hepatosplenomegaly. It can be hepatos kidney syndrome. It can be hepatopulmonary. So liver, lung, liver, spleen, liver, kidney, okay? And there can also be portopulmonary hypertension and cirrhotic cardiomyopathy. These are all complications, but in these ones, look, just get the common three. Common three, keep that in your mind, so that in case you have any question like that, you know how to answer it. Okay? Okay, good. Now, there's this question. This is just an MCQ, so I'm going to read it so that I can give Dr. Tasnim some rest. I'm going to read it for you. In terms of duration, the patient states that ascites developed over just 3 weeks ago, or just 3 weeks. On further exam, he has some spider navy, yellowish discoloration of the eyes, and pedal swelling. Which of the following may be the cause? Select only one. Select only one. What is
cirrhosis?
Beautiful. Why cirrhosis? Why did you go for cirrhosis, Dr. Raj? Why did you go for cirrhosis?
Yes, the presence of jaundice.
Beautiful.
And spider nevi.
Beautiful.
And pedal edema.
Beautiful.
This shows that it is going to be something like a portal hypertension associated, so it should be cirrhosis. Okay, now, good. Abdominal trauma is not going to cause jaundice or pedal swelling.
Beautiful.
Tuberculosis is also not going to cause so much of pedal swelling unless and until it is advanced, like some sort of a hypoproteinemia. And colonic cancer is going to be only ascites and not the other features.
Beautiful. So now that you just mentioned this, let's use this as a teaching point. What other features of chronic liver disease will you be able to remember? Can you tell me more? We've learned about spider navy, we've learned about yellowish discoloration of the eyes, we've learned about pedal swelling. What other features of chronic liver disease, or
clotting and bleeding time might be prolonged, PTT, coagulation abnormalities can come.
No, take your time, take your time. We're talking about physical exam. We're not talking about labs. Physical exam.
Okay. Physical
exam features. Yeah, let's go. So what are the things you see on physical exam that can tell you that this patient...
There can be a flapping tremor if there is going to be a hepatic coma.
Okay, that's hepatic encephalopathy, right? Okay, let's continue.
And then you can have a congestive hepatomegaly, and there can be raised JVP also.
Usually raised JVP goes with if there is, liver congestion from right heart failure, right? Okay.
Yes.
Let's continue. Yes. What else? Can you have gynecomastia?
Yes, gynecomastia.
Can you have parotid enlargement?
Parotid enlargement, correct?
Can you have ritus because of the deposition of bile salts?
Pruritus.
Yes. Can you have palmar erythema? What about splinter hemorrhages? Not really.
That is subacute bacterial enteritis.
Yeah. What about caput medusae around the stomach?
Yes. Caput medusae.
What about if you examine the groin, the testes? What will it be, big or small? Testicular atrophy, right? When they have chronic kidney disease. Beautiful, beautiful. So look, but this question was even saying in terms of duration, but you were able to use the spider navy, the yellowish discoloration of the eyes, the pedal swelling to say that this is cirrhosis. Now listen to what UpToDate also has to say about this. The answer is cirrhosis, and that is right. And the patient has signs of chronic liver disease. That's what Dr. Raj said. Secondly, time factor is key, because Dr. Raj said that, look, this can't be abdominal trauma. And I like that, because you are very confident that, look, this cannot be, because abdominal trauma, as soon as they have the trauma, it will happen. It's not going to take weeks for the person to develop the distension. So the time course over which the distension develops depends on the etiology of the ascites. So this is what UpToDate is saying. It may develop over the course of days. So that is bloody ascites due to trauma. So if the person might have had some form of trauma, if the ascites is going to develop, you want to see it in the course of days. So if you are looking at the question stem and you're looking for duration, look for days or instant, okay? Ascites or months, if it is over a period of months, then you are thinking about malignant ascites like ovarian cancer, hepatocellular cancer. Ascites due to cirrhosis and or alcoholic hepatitis usually develops rapidly over a few weeks. So please write this down. Few weeks, ascites due to cirrhosis. Instant and over days, ascites due to trauma. All right? And then over months, think about malignant ascites. Let's keep it simple. Over months, think about malignant ascites. So let me stop sharing and then let's go to our whiteboard and let's get this thing right. So Dr. Raj, what was the learning points there? Days. It's what?
Yeah, duration.
Trauma. Beautiful. Okay, so if the question stem says over a few weeks, what are you going to think about?
Cirrhosis with portal hypertension.
Beautiful. Sorry, my handwriting is funny. Okay, what about months?
Malignancy.
Awesome. This is it. Malignancy. Okay. So this is it. So even when you are reading the question, alone, the question should tell you, is this trauma? Is this cirrhosis? Is this malignancy? Depending on how the question is being put. Okay. So Dr. Raj, will you want to take this question for me again? Will you want to take this question?
Yes.
Okay, good. Let's go.
So you are practicing in your clinic today. Do I read the question?
Yeah,
no,
read
it's
the
the
question.
same.
Read the question.
Okay.
No, there's a new.
Yeah, you are practicing in your clinic today. A long-time patient of yours comes into the clinic with abdominal distension. On further exam, he has some spider nevi, yellowish discoloration of the eyes and pedal swelling. Which of the following may be the cause? Patient asks you about what can possibly go wrong with him. List 7 complications of cirrhosis.
Yes, so now we are looking at cirrhosis and its complications. Dr. Raj, can you tell me some of them?
Yes, so portal hypertension.
Portal hypertension, what else?
Hepatic encephalopathy.
Hepatic encephalopathy, what else?
Coagulopathies.
Coagulopathy.
Total vein thrombosis. And then
yeah, I see people writing GI bleeding, portal hypertension, lower GI bleeding,
gastric hemorrhage. Yeah.
Beautiful, beautiful, beautiful. So this is right from Up to Date as well. Up to Date wants you to know that complications of cirrhosis can be variceal bleeding, ascites itself, okay? Spontaneous bacterial peritonitis, beautiful. Hepatic encephalopathy, and I saw somebody just writing hepatocellular cancer, and Up to Date also says the same thing, okay? Hepatorenal syndrome. Please write these answers down. Hepatorenal syndrome, hepatopulmonary syndrome. As I said, always remember, it can go to the brain. It can be a relation between the liver and the lung, liver and spleen, liver and kidney, okay? So even if you remember all these structures around the liver, they alone can help you to sort things out. Hepatic hydrothorax, portopulmonary hypertension, even some form of cardiomyopathy, cirrhotic cardiomyopathy, and portal vein thrombosis. Now, I want to give you a clue here. When you are learning all this, one thing you also want to learn is how to manage some of the common presentations. So if I were you, I'll write it down. How am I going to manage a patient with variceal hemorrhage? What is going to be my approach to a patient with ascites management? Which antibiotics will I use for spontaneous bacterial peritonitis? How will I manage a patient with hepatic encephalopathy? What will be my management and investigations for a patient with hepatocellular carcinoma? These are the common ones. When it comes to hepatic hydrothorax and the rest, I wouldn't waste my time there. But if I know how to manage variceal hemorrhage, if I know how to manage ascites, if I know how to manage spontaneous bacterial peritonitis, if I know how to manage hepatic encephalopathy, I am in good company. So you see the approach we are using when you are dealing with objectives. When you are dealing with objectives, don't just read, but rather read and apply. Read and apply and ask yourself, put yourself in the examiner's situation, because the MCC has given you the objective. Now, if I were an examiner, how would I set a question? All right, okay, good, let's go on. let's go on. So patient inquires about the risk factors for decompensation of liver failure. List 4. Can anyone help me? What are the risk factors for decompensation? So if somebody has liver disease, what?
Alcohol.
Alcoholic. Okay, sure. What else?
Infection.
Infection. What else?
Hepatitis B history, hepatitis C history.
Well, you know, no. The question is asking risk factors for decompensation. Hepatitis B will lead to cirrhosis, but what will cause somebody with cirrhosis to decompensate?
Drugs.
Okay.
Drugs. What else? What else? What else? Look, bleeding. So if the patient has variceal bleeding, the patient can decompensate. Dr. Raj, do you see that most of the time when they have variceal bleeding, eventually then a lot of complications come in and they eventually die? Infections.
Yeah.
Patients who have, you know, spontaneous bacterial peritonitis. Alcohol intake. So the patient already has cirrhosis and the patient now keeps drinking alcohol. That is bad. Even some medications as well. And I think somebody wrote dehydration. And I think Dr. Reza, you know, so dehydration can lead to sodium retention. Some form of dehydration can lead to some form of sodium retention, even constipation. And if the patient has liver disease and the patient becomes obese, why? Because if the patient keeps depositing fat around the liver, fatty liver disease, worsening fatty liver disease, then we are in trouble. Okay, good. Next question. A year later, you were in the hospital as an ER doctor on call when the patient was brought in. So the same patient we are talking about, he had decompensated cirrhosis. This is the 3rd episode in the last 6 months. Patient's family inquires about what his definitive treatment should be. What is the definitive treatment for somebody who develops recurrent decompensation? What's your answer? What's going to be your answer?
Liver transplant.
Beautiful. Thank you very much. Liver transplant. Beautiful. People are getting it. We are now getting it. Up to date, we say, once decompensation has developed, please write this down. Once decompensation has developed, patients should be considered for liver transplant. You know, if you are going to use the objectives to learn and up to date as your source, you will never go wrong. Once decompensation has developed, patients should be considered for liver transplant. This is from our #1 source, up to date, which the MCC wants you to study with. Okay.
If I would like to say tips, what sort of a question will be there?
This what?
Tips. The palliative.
Because the question is asking about definitive, right?
Definitive.
Tips will
So
only
if they
be
ask palliation.
Yes, then tips will come in. But definitive, okay. The person needs a new liver. The person needs a new liver, straight up. Okay, good. And you know, the questions are, it can be tricky, but if you know your stuff, like the way we are going through this step by step, you should not be beaten. I don't think we've done any outrageous discussion. These are things you know, but at times just how to put it into context is what makes the difference. Okay, so now I go again. You are practicing in your clinic today. A long-term care patient of yours comes into the clinic with abdominal distension. On further exam, he has all that we've talked about. Apart from ascites, list 6 other clinical findings of advanced cirrhosis. I know we've talked about it in some of the points, so I'll just go through it. So the patient can even have pleural effusion. Remember, I told you that whenever you're talking about ascites or abdominal distension, think about the relationship between the liver and the lungs, the liver and the kidney, the liver and the spleen. Then you can add other things. So pleural effusions, spider angiomata or spider navy, palmar erythema, okay, abdominal wall collateral. That's what we see, the caput medusae and all that, and the blood vessels on the abdomen. Jaundice, muscle wasting, gynecomastia, okay, leukonychia. I think somebody, yeah, okay, some people are writing answers for me. Hepatomegaly, splenomegaly, parotid enlargement. So you must know, like when it comes to ascites, you must be able to recite it. Next question. I need someone to volunteer because this is a new question altogether. Can somebody volunteer for me? Who wants to volunteer? Who wants to volunteer? I want you to volunteer because I want us to cover abdominal distension. Yes,
it's
please.
me, Dr. Anam. I want to volunteer.
Sure, Dr. Anam, let's go.
Yeah, shall I read the question first? Yeah. A 78-year-old sick-looking man was brought to the emergency by ambulance with ongoing history of failure to cope at home and lethargy. On further evaluation, you notice that he is emaciated and pale. Abdominal examination showed ascites with an umbilical nodule. List 3 conditions which present with ascites and an umbilical nodule.
Beautiful. Can you tell me? Can anyone help me? Ascites with umbilical nodule. So this is an equation. Ascites plus umbilical nodule. What are your answers? Tell me.
Peritoneal carcinomatosis.
Peritoneal carcinomatosis. What else?
Sister Joseph's nodules.
Well, Sister Mary Joseph's nodule is the name of the nodule, right? But what are the causes of Sister Mary Joseph's nodules? Yes, tell me something sweet. Tell me something sweet. Oh, I see Dr. Bada is saying colon cancer.
Primary CA liver.
What?
Gastric CA.
Gastric CA, liver malignancy. Beautiful. So let's look at the answers that UpToDate provide. Gastric CA, colon cancer, hepatocellular cancer, even abdominal lymphoma. So please, today you must be able to write this equation. You must be able to write this equation easily. Let me clear my table right away. Let me clear all my drawings. Okay, so if there is ascites plus umbilical nodule, you must be able to deal with it. What are the things you will know? You have to be able to deal with this easily. You should not suffer with it because we've already learned it in class. If you meet it anywhere, whether you are sleeping, whether you are walking in Walmart, whether you are at the dining table, you should be able to recite these: gastric cancer, colon cancer, hepatocellular cancer, lymphoma. All right? All right? Can we move on? Okay, good. So UpToDate says this: an umbilical nodule that is not bowel omentum, that is Sister Mary Joseph's nodule, provides evidence for cancer as the cause of ascites. Gastric cancer, colon cancer, hepatocellular cancer, or lymphoma can cause ascites accompanied by umbilical nodule. UpToDate. UpToDate should be yours. Like, you should check things with UpToDate. Okay, good. So that same patient, what non-blood investigation will you request for the evaluation of the abdomen of the patient with ascites? Non-blood investigation. What will you request? Non-blood investigation. What?
Ultrasound.
Well,
Ultrasound.
Ultrasound of the ear. Is it ultrasound of the ear?
Abdominal ultrasound.
Exactly. Be specific. Abdominal.
Abdominal ultrasound. Yeah.
You know, in your answers, be specific, please. Don't just say ultrasound. Is it ultrasound of the leg or what? Abdominal ultrasound. So you see the way we answer questions and we lose marks? We know you know, but how you put the answer makes a big difference. So you wanted to find the cause of the ascites and to rule out spontaneous bacterial peritonitis. What one test will you perform? If you want to know the cause of ascites and to rule out SBP, what test will you perform? What test will you perform?
Ascitic fluid analysis.
Well,
peritoneal fluid analysis.
Well,
Parasitosis.
Yes.
Abdomen.
Ascitic fluid analysis, you do that after you've drawn the fluid.
Yeah.
CBC.
So your answer should be no. Your answer should be abdominal paracentesis, because
Okay.
what test will you perform? You do the abdominal paracentesis, then you will do the investigations on it. Okay. So I know you know your answers, but be stepwise in the way you answer, or else you will lose some marks. Okay. Now that we've talked about paracentesis, I'm sure you should know the next question, which is coming. After the test you requested is obtained, list 4 common assessments you like to perform on the sample obtained. So in other words, if you get ascitic fluid, what can you do with ascitic fluid?
Cell count.
You can
glucose.
What else?
Count glucose, proteins.
Glucose, protein, what else?
LDH. LDH.
Okay, so can you tell me the significance of each of them?
Transudate or exudate?
Well, transudate or exudate, that has something else to do. But what are the things you can do with acidic fluid? I think you've mentioned some of them. You can just even look at appearance. What can you do with acidic fluid? You can just look at appearance. That's number one. You can do serum to ascites albumin gradient determination. That's a SAD, because that will help you to know whether it is transudate or exudate. Okay? You can also do cell count and differentials. And then you can do total protein concentration. So these are 4 common things we do. But if you want to take the game to another level, then remember that you can perform other tests. And some of those tests you can do you can culture it. Okay? You can culture it. And when you culture it, it will help you to know the organism which is causing the ascites. You can do glucose concentration. And glucose concentration will help you to know whether this ascites is malignancy, infection, bowel perforation. Because if it's a bacterial infection, the glucose levels will go down. LDH, if it's elevated, can help you to know whether it is malignancy, infection, or bowel perforation. You can even do gram staining. You can do amylase concentration, because if the patient has, ascites as a result of pancreatitis, amylase levels will be increased. Okay? And then you can also do tuberculosis smear. Remember that when we're studying, we said that intra-abdominal tuberculosis can lead to abdominal distension. And then cytology as well can be done, and triglyceride concentration and bilirubin concentration. So these are all investigations you can do. But please, before you get into these deep ones, remember, you're going to do appearance. You're going to do SAG, that is serum to ascites albumin gradient determination. You're going to do cell count and differentials. You're going to do total protein concentration. So if I were you, I'll just take a screenshot of this one. What will I do with acidic fluid? At least I should know at least 4 things I can do. I can inspect it for appearance. I can do the SAG. I can do the cell count and differential. I can do total protein concentration. Before you add LDH, culture, gram stain, amylase, because those ones are on another level. But if you're able to mention the simple ones, in the exam, simple things or common things are common. Okay, good. So you like to know if the patient has ascites as a result of portal hypertension or not. What will you do? We've already talked about it. How to determine if ascites is as a result of portal hypertension or not. You have to calculate the SAG. The SAG is serum to ascites albumin gradient. So how you do it is that you get the serum, that's the blood, you calculate the albumin in there, you also get the ascites, you check the albumin in there, and then you find the ratio. Now, the presence of a gradient more than 1.1 predicts that the patient has portal hypertension. So if the gradient is more than 1.1 gram per deciliter, it means the patient has portal hypertension. If a gradient is less than 1.1, it indicates that the patient does not have portal hypertension. Okay, so how do you determine that the patient has portal hypertension from acidic fluid? Just calculate the SAM. Write it down. Serum to ascites albumin gradient. Now, this same patient who has the umbilical nodule, the question says that 4 days into the patient's admission, you note that a colleague of yours has written the diagnosis spontaneous bacterial peritonitis on the patient's chart. List 4 signs or symptoms of the diagnosis. Please, this one, I want you to type your answers. How can you tell that the patient has spontaneous bacterial peritonitis? How can you tell? Type your answers for me. As we try to wrap up the class, type your answers. How will you tell that this patient has spontaneous bacterial peritonitis? Someone said loss of consciousness, fever, abdominal pain. Beautiful. Abdominal pain, beautiful. Like somebody with ascites and new onset abdominal pain, you're thinking about spontaneous bacterial peritonitis, right? How will you tell spontaneous bacterial peritonitis? The patient develops fever. The patient develops chills. If the patient develops abdominal pain. If the patient develops ileus, if the patient develops hypotension, if the patient develops encephalopathy, if all of a sudden you see that the creatinine is rising, the urea is rising, the eGFR is declining, that is acute kidney injury. So what are the signs of SBP? I will write it down: fever, chills, abdominal pain, ileus, hypotension, encephalopathy, acute kidney injury. These are the signs of spontaneous bacterial peritonitis. Now, how will you manage the above condition the patient has developed? List two options. In other words, how will you manage spontaneous bacterial peritonitis? Will anyone help us? Spontaneous bacterial peritonitis. How will you manage it? How
IV antibiotics, IV antibiotics, cephalosporins.
So you can do cefotaxime or ceftriaxone, and you can do IV albumin. Cefotaxime, so write it down: cefotaxime, ceftriaxone, and I can do IV albumin. And the teaching point is this: you've got to give IV antibiotics, okay? And you have to modify the response depending on the culture results. So this is what and then you got to give IV albumin. It decreases mortality by lowering the risk of acute renal failure. So why do we give IV albumin? To reduce the risk of acute renal failure, because ascites has a relationship with renal failure. That is, that's what we're talking about. Whenever the patient has ascites, think about the lungs, think about the kidneys, think about the spleen. So the two main things you want to do for a patient with spontaneous bacterial peritonitis: ceftriaxone or cefotaxime and IV albumin. These two, especially albumin, will reduce the risk of renal failure in a patient with spontaneous bacterial peritonitis. So I'm going to take you through the approach to the management of suspected spontaneous bacterial peritonitis. So if you have a high suspicion of bacterial infection based upon the signs and the symptoms, then what you want to do is that you want to culture the acidic fluid. You want to culture blood, urine, sputum, and acidic fluid for polymorphonuclear leukocytes counts. And immediately you want to start your empiric antibiotics. And this is from up to date. You want to do cefotaxime and you want to give IV albumin. So two things you give in patients with spontaneous bacterial peritonitis: cefotaxime or ceftriaxone and IV albumin. If you have a low suspicion of bacterial peritonitis based on the signs and symptoms, then you want to do abdominal paracentesis. You want to, screen for is there any polymorphonuclear leukocytes in there, and it should be available in 1 to 4 hours, and bacterial cultures, and immediately you want to start. So far as you're thinking about spontaneous bacterial peritonitis, think about starting the patient on IV cefotaxime, IV ceftriaxone, IV albumin. And we've learned today that IV albumin reduces the risk of renal failure in patients with ascites. So you realize that now you can confidently say you have conquered some major parts of the QE1 abdominal distension objective, but that is not all. Now I'm going to show you this. I need you to write this down. So when it comes to the QE1 objective number 1, abdominal distension, we've been playing around just number 1, ascites and exudative and transudative stuff. That's all we've been doing. We've not been able to, you can't cover everything, but what are the topics you need to also review when it comes to this? You've got to review intestinal obstruction. So if I were you tonight, before I sleep, I'll make sure that I review intestinal obstruction. I will make sure that I've reviewed paralytic ileus. I will make sure that I've reviewed abdominal masses. In fact, another objective talks about abdominal and pelvic masses as well. Part of it is that you also need to review irritable bowel syndrome as well. And you need to also review organomegaly, like hepatomegaly. So you must know causes of hepatomegaly. You must also know pelvic masses. So as I said, the abdominal distension itself has a lot of things, because we said that ovarian cancers can cause abdominal distension, that is ascites. So pelvic masses can lead to that, organomegaly, hepatomegaly can do that. So you need to review all these topics. Don't just review what we've reviewed in class today. The replay will be available to you, but don't just review that alone. Review all these topics and have more for you. You also have to review historical features, differentiating ascites and distended bowel from abdominal masses. So how can you tell the difference between ascites and, say, intestinal obstruction? Okay, how can you tell the difference in terms of physical exam, in terms of history? Remember that we meant, even with history of development of ascites, if it is sudden after trauma, you're thinking about bleeding, or if it goes for days. If it is weeks, you're thinking about cirrhosis. If it is months and it is insidious, then you're thinking about malignancy. You've got to learn about the causes of ascites itself. And then you've got to also learn about how to investigate patients with abdominal distension. So if I were you, what I'll do is I'll take intestinal obstruction. How am I going to investigate this patient? I'll take paralytic ileus. How am I going to investigate this patient? I'll take abdominal masses. How am I going to investigate this patient? I'll take irritable bowel syndrome. How am I going to investigate this patient? I'll take organomegaly like hepatomegaly. How am I going to investigate this patient? Pelvic masses. How am I going to investigate this patient? Now, you also have to learn the causes of bowel distension. We've learned ascites already, but you've got to learn the causes of intestinal obstruction. So if it's an elderly man, history of abdominal surgeries, that is, if the patient has developed adhesions. If it's a young newborn baby, possibly intussusception, volvulus, right? If it's a very old man who has never had surgery before, think about colorectal cancer and how to investigate the patients with abdominal distension. Today, we learned how to investigate it. We learned the ultrasound we are going to request. We learned the acidic fluid we are going to tap. All right? Dr. Liu say, thank you. Yes, this is how to learn for the QE1, seriously. And how to manage ascites. That's a topic on its own. IV fluids, daily weight, salt restriction, fluid restriction. How am I going to manage intestinal obstruction? I'm going to pass an NG tube. I'm going to, urgent surgical referral. I'm going to pass a urinary catheter to monitor urine output. I'm going to monitor the patient for spontaneous perforation of the bowel. How am I going to manage paralytic ileus? Paralytic ileus, I want to rule out electrolyte imbalances, right? You want to know all these things at your fingertips. Please, until you've covered these topics, this and this, you've not covered Objective 1. But if you're able to cover this and this, then you know you've covered Objective 1.